Welcome. In this session, we'll be discussing about vitreoretinal surgery, or more specifically, pars plana vitrectomy. Indications of pars plana vitrectomy include removal of vitreous opacities such as hemorrhage and exudates, removal of intraocular foreign bodies, relieving vitreoretinal traction, closure of retinal breaks, and accessing the subretinal space. At a very simplistic level, PPV consists of making 3 or 4 sclerotomies to enter the vitreous cavity to enable intraocular maneuvers. One of the sclerotomies is used as an infusion port to infuse fluid such as BSS, air or gas, and the other 2 ports is used to insert the endo-illuminator and to introduce various instruments and fluids. Normal retina shows a sheen-like surface reflection, but areas with surface membranes have a more matte appearance. It is important to remember that in the absence of posterior vitreous detachment, a surface membrane is continuous with the posterior vitreous cortex. Also, the retina itself rarely contracts, as intraretinal fibrosis does not occur unless there is necrosis of tissue. And changes in contour of retina, including retinal detachment, can occur due to vitreous traction, epiretinal membrane, and subretinal fibrosis, each of which can be dealt with by PPV. Physical forces applied on tissue by surgical maneuvers include peeling, shearing, and phatic failure. In peeling, as represented by this diagram, force is generated in the axis of collagen fibers of tissue, which is to be detached from underlying structure to which it is adherent. And peeling where vitreoretinal adhesion is very strong, such as may occur in diabetic retinopathy and retinopathy of prematurity, can induce iatrogenic retinal breaks. And it is important to remember that peeling cannot be done at vitreous base because of very low tensile strength of peripheral retina and strong adhesion of the vitreous base to this region of retina. In shearing, force is generated by 2 right-angled edges in contact with each other and moving past each other in opposite directions, as a result of which adjacent portions of a tissue engaged between these 2 edges are dragged away from each other. Vitreous cutters and scissors employ shearing mechanism. In a vitreous cutter, there is an outer tube which has a port which aspirates tissue and an inner tube which moves forwards and backwards within the outer tube. The aspirated tissue is cut by shearing when these 2 edges move past each other during forward movement of the inner tube, and again when these 2 edges move past each other during backward movement of the inner tube. Scissors also employ shearing force to cut tissue, but since the blades of a scissor are not parallel to each other, they generate lateral and twisting forces which may tear surrounding adhesions. And phatic failure occurs when repeated elongation and compression of a tissue results in weakening of that tissue, examples of which include phacoemulsification and phacofragmentation, both of which use ultrasound energy. Currently, transconjunctival sutureless microincisional vitrectomy, or MIVS, as shown here in this photograph, is the standard procedure for pars plana vitrectomy. Benefits of MIVS include no requirement of conjunctival peritomy, thus reducing conjunctival scarring, no requirement to close sclerotomy or conjunctival incisions with sutures, a shorter operating time, reduced risk of iatrogenic retinal breaks, less post-operative discomfort, and faster visual improvement. This is probably the most commonly used vitrectomy machine worldwide, which provides multifunctionality for pars plana vitrectomy, which can be controlled on this monitor. The ports for infusion and suction along with cassette attachment is located here. This module having the ports for the electrically driven tools such as diathermy and phacofragmatome. This module having the ports for the pneumatically driven tools such as the vitreous cutter and the viscous fluid injector. These 2 modules providing illumination and a 532 nanometer laser provided by this module. This is a smaller but a very useful version of this equipment which lacks a laser module, and this photograph shows connected tubes for suction, infusion and vitreous cutter attached to their respective ports. The purpose of the infusion system is to maintain intraocular pressure intraoperatively, and an adequate intraocular pressure of approximately 45 mm of mercury reduces the risk of bleeding and prevents deformation of globe and meiosis intraoperatively. But before fluid infusion is started, the tip of the infusion cannula should be visualized through the microscope as shown here in this diagram and confirmed to be inside the vitreous cavity at the pars plana region. Otherwise, suprachoroidal effusion as shown here in this diagram may result if the tip of the infusion cannula lies within the ciliary body, and care should be taken during rotation of globe and scleral depression to prevent the tip of the infusion cannula from retracting back into the suprachoroidal space, and this is very important to remember. And to tackle suprachoroidal effusion after it has occurred, infusion pressure in the vitreous cavity needs to be increased either by repositioning the tip of the same cannula or by positioning the tip of a larger cannula inside the vitreous cavity through the pars plana epithelium. Following this, the choroidal effusion decreases, often by egress of intraocular fluid around the original cannula. And for vitrectomy systems allowing real-time IOP monitoring, accurate IOP measurements require that the patient's eye level should be measured and entered into the machine before beginning surgery. As we have mentioned, vitreous cutter works by suction to imbricate tissue or vitreous to the cutter port, and that it has an outer tube with a cutting port near its tip and an inner tube with a sharp edge which moves to and fro inside the outer tube. And because of this to and fro movement of the inner tube, this type of cutter is known as guillotine type cutter. Ideally, vitreous cutter should not displace the tissue to be removed to avoid vitreoretinal traction. This tissue displacement can be minimized by measures decreasing flow through the port, such as high cutting speed, smaller gauge cutters, and low suction force. This photograph shows smaller gauge cutters called 23G, 25G, and 27G, and this diagram shows the diameters of the tips of the smaller gauge cutters in comparison to the conventional 20 gauge cutter. And as higher cutting rates produce less traction on nearby tissues, the cutting port can be positioned closer to the retina with less risk of creating iatrogenic retinal breaks. Higher cutting rates have been achieved with dual pneumatic cutters, in which both the forward and the backward movement of the inner tube of the cutter is generated by separate air pulses in opposite directions, instead of the backward movement being generated by a spring, and with dual blade cutters which have two pairs of cutting edges to cut both in forward and backward motion of the inner tube. The open time of cutting port can also be adjusted so that faster removal of vitreous can be achieved during core vitrectomy by keeping the cutting port open for a longer period, while during vitreous-based dissection, vitreoretinal traction can be reduced by keeping the cutting port open for a shorter period. We'll discuss core vitrectomy and vitreous-based dissection when we discuss surgical techniques. Vitrectomy cutters also allow reflux, which is fluid movement into the eye through the cutter port, which can be used to dislodge tissue inadvertently engaged by the cutting port, and also can be used to separate retina from membranes to be removed. When removing the vitreous cutter, cutting should be activated to prevent vitreous incarceration at the sclerotomy, and free egress of infusion fluid from the sclerotomy ports upon removal of instruments confirms the absence of vitreous incarceration at the sclerotomies. Suction generates flow within the vitreous cutter from the eye to the machine, which imbricates tissue within the cutting port and aspirates the tissue after it is cut. A separate suction line is available on most machines for extrusion cannula, which we'll discuss later. Parameters such as suction, cutting rate, and power should ideally be under linear control with the foot switch. In proportional vitrectomy systems, usually suction is linearly controlled by the treadle of the foot switch, with more the treadle of the foot switch being depressed vertically, the higher the suction being attained, while the cut rate remains unchanged. In dual linear vitrectomy systems, both cut rate and suction can be controlled linearly and independently, with vertical movement of the treadle called pitch usually controlling cutting speed, and horizontal movement of the treadle called yaw usually controlling suction level. Illumination inside the eye can be provided by an endoluminator probe or by a chandelier system. The endoluminator probe, as shown here in this diagram, has to be held by the surgeon and introduced into the eye either through the supratemporal or supranasal sclerotomy port as required, while the chandelier system as shown here in this diagram, is attached and fixed to a forced sclerotomy and thus frees up both hands of the surgeon for bimanual maneuvers and also provides a wide field of illumination from a source more distant from the retina. As regards the operating microscope, stereo viewing, coaxial illumination, and XY focus and zoom control are essential. Visualization of the posterior segment of the eye during surgery can be enabled with a contact lens, an example of which is shown here in this photograph, which needs to be placed over the cornea and requires a skilled assistant to hold and stabilize, or through a non-contact system as shown here in this photograph, which is attached to the microscope objective with a stereo inverter, and it is said that non-contact systems provide lower stereopsis, lower resolution and lower magnification as compared to contact lenses. Heads-up display refers to the surgeon viewing a monitor instead of through the eyepiece of the microscope, and it is said to provide increased depth of field, higher magnification and higher spatial resolution with lower illumination inside the eye, and is definitely ergonomically better for the surgeon. And intraoperative real-time OCT imaging as shown here in this photograph is provided by some microscope systems. For endolaser, 532 nanometer laser is preferred over 810 nanometer laser because, as we have discussed in the session on lasers, the former causes less damage to choroid and allows coagulation of bleeders in addition to retinal coagulation for retinopathy around retinal breaks as shown here in this diagram and panretinal photocoagulation. But any laser application should be adequate but not excessive because coagulation causes tissue necrosis and stimulates reproliferation. Endolaser can be done under Fluid-PFCL or PFCL as we will discuss, and this photograph shows the various types of laser probes available which can be introduced through a sclerotomy port for application of laser. Intraocular diathermy or endodiathermy can be used to mark retinal breaks whenever retinal breaks are detected in a detached retina, so that the retinal breaks can be easily identified for laser photocoagulation following attachment of the retina, creating a drainage retinotomy and cauterizing bleeders. Endodiathermy needle should be bipolar, and endodiathermy can also be done under Fluid-PFCL or PFCL. Like a phacoemulsifier, a Fragmatome also uses ultrasound but to emulsify nuclear fragments of crystalline lens dislocated in the vitreous cavity. Fragmatomes require larger sclerotomies, typically 20G sclerotomy, but 23G fragmatomes are also available, and the needle of a fragmatome is slightly longer than the needle of a phacoemulsifier. Common instruments used during vitreoretinal surgery include scleral indenter, extrusion cannulas, which we will be discussing later in this session, a variety of forceps such as end gripping, ILM, max grip, asymmetric, serrated, pick and IOFB forceps, and scissors such as horizontally curved scissors, straight scissors and vertically curved scissors, and probes such as endoluminator, diathermy and laser, which we have discussed. Adjunct tools used during vitreoretinal surgery include tamponades and stains. Intraoperative tamponade can be provided with perfluorocarbon liquids, and post-operative tamponade is provided with gas or silicone oil. Gas and silicone oil are used to eliminate flow of intraocular fluid through a retinal break to attach a detached retina. Two factors determine the efficacy of a tamponading agent: interfacial tension and buoyancy. Interfacial tension, as represented by these two red arrows in this diagram, acts along the surface of a bubble at the interface of two fluids and prevents disruption of the interface between the fluids. Interfacial tension is more important than buoyancy in preventing the flow of intraocular fluid through the retinal break into the subretinal space. Interfacial tension also prevents the tamponading agent itself from passing through the retinal break into the subretinal space, and it has been found that gas-fluid interface has a higher interfacial tension than silicone oil fluid interface. Buoyancy, as represented here in this diagram, is the upward force exerted by the bubble of a lighter than water tamponading agent. Buoyancy thus determines the location of the retina opposed by the bubble in a certain head position, and thus post-operative head positioning becomes important to get the maximal benefit from this force. And as with interfacial tension, gas also exerts a higher buoyancy force as compared to a similar volume of silicone oil. But as we shall see, silicone oil provides a longer post-operative tamponade as compared to gas. Uses of intraocular gas include occluding retinal breaks and tamponading detached retina during and after vitrectomy for retinal detachment and macular hole. But in addition to vitrectomy, intraocular gas can also be used for pneumatic retinopathy to treat selected cases of retinal detachment, as we will be discussing in the next session, and in certain situations during or following scleral buckling. Intraocular gas can also be used to displace submacular hemorrhage away from the macula. Air injected in the vitreous cavity is non-expansile, but a pure gas bubble is expansile. A pure gas bubble injected into the vitreous cavity has three phases: expansile, equilibration, and dissolution. In expansile phase, volume of the gas bubble increases because the rate at which nitrogen dissolved in intraocular fluid enters into the gas bubble is higher than the rate at which the injected gas enters into intraocular fluid. During equilibration phase, partial pressures of nitrogen in bubble and intraocular fluid become equal, but partial pressure of the injected gas in the bubble is still higher than that in intraocular fluid, and the injected gas continues to exit the bubble into the intraocular fluid, so the bubble slightly decreases in volume during this phase. Dissolution phase begins when partial pressures of all gases in the bubble equal their partial pressures in intraocular fluid. During dissolution phase, all gas molecules exit the bubble and move into intraocular fluid, resulting in decrease in volume of the bubble, and dissolution phase is the longest among the three phases. Before injection, pure gas may be mixed with air in a specific concentration depending on the type of gas, so that the intraocular bubble does not expand following injection, and this is called a non-expansile gas-air mixture. A non-expansile gas-air mixture helps in more complete filling of the vitreous cavity at the end of surgery, with reduced risk of raised intraocular pressure post-operatively. In this table, this column shows the time to maximum expansion of the intraocular bubble following injection of pure gas. This column shows the respective non-expansile concentrations, which when injected into the eye does not expand in volume further, and this column shows the longevity of the intraocular bubble. Among the gases available, sulfur hexafluoride and perfluoropropane are more commonly used, and these two figures are important to remember. When nitrous oxide is used as an inhalational anesthetic in a patient with an intraocular gas bubble, the nitrous oxide rapidly diffuses from the intraocular fluid into the gas bubble, thereby increasing the bubble volume significantly, which may result in retinal and choroidal vascular occlusion due to severe increases in intraocular pressure. And when gas injection is planned during vitrectomy under general anesthesia, nitrous oxide needs to be discontinued 15 minutes prior to intraocular injection of gas, and this is very important to remember. Non-expansile air gas mixture for intraocular injection should be prepared immediately prior to intraocular injection. A silicone tubing is attached to the outlet of the gas cylinder at one end and to 2.22 millipore filters at the other end, and a 50 ml syringe for withdrawing the gas is connected to the outer filter. Pure gas of desired volume is then loaded in the syringe from the cylinder, following which the inner filter is disconnected from the outer filter to allow withdrawal of desired volume of room air into the syringe. The inner filter is then removed from the hub of the syringe, and the hub of the syringe is then connected to the infusion cannula. Head positioning following gas injection is important to obtain the maximum effect of buoyancy force, and the head position should be such that the retinal break remains uppermost within the eye immediately post-operatively till partial chororetinal adhesion from laser or cryo around the retinal break occurs, which may take from 2 to 7 days. Otherwise, face down positioning following gas injection helps in reducing risk of pupillary block and cataract in phakic eyes and of optic capture in pseudophakic eyes. Significant increases in intraocular pressure can occur in the initial 2 to 4 days following injection of pure gas, which may potentially lead to central retinal artery obstruction, but this is less likely to occur with a non-expansile air gas mixture, and monitoring of intraocular pressure in the early post-operative period following intraocular gas injection is very important, and applanation tonometry has been found to be the most accurate for this purpose. Prophylactic oral acetazolamide and topical timolol are required, particularly in patients with pre-existent glaucoma. During air travel, rapid decrease from atmospheric pressure to cabin pressure causes the gas bubble to expand in size, with significant increase in intraocular pressure, and central retinal artery occlusion has been reported in this situation. So air travel should be allowed only after complete disappearance of the gas bubble from vitreous cavity, and this is very important to remember. Similar phenomena may occur during scuba diving following rapid ascent to the water surface after a dive, but slow changes in altitude may be compensated by the eye's outflow facility without significant increases in intraocular pressure. Though difficult, visualization of the fundus through a gas bubble as seen here in this photograph is possible, along with delivery of laser through the gas bubble for photocoagulation, and so long as the gas bubble occupies significant portion of the vitreous cavity, the patient's visual acuity will be poor, for which the patient needs to be counseled pre-operatively. Silicone oils are used for long-term retinal tamponade and are made up of repeating units of siloxane. They are clear viscous liquid immiscible with water. The nature of the siloxane polymers determine two properties: specific gravity and viscosity. Specific gravity determines whether a silicone oil bubble in the eye exerts upward or downward force, with this diagram representing bubble of a lighter than water silicone oil floating over water and exerting an upward buoyant force. And viscosity determines difficulty in injection and removal of silicone oil from the eye and the tendency of the silicone oil bubble to emulsify over time. The most commonly used silicone oil for ophthalmic use is polydimethyl siloxane, which is lighter than water, and depending on chain length of the polymers, viscosity of PDMS range from 1000 to 5000 centistokes. Heavier than water silicone oil or heavy silicone oil can provide inferior tamponade as shown here in this diagram, and can be produced either by introducing trifluoropropyl side chains on silicone atoms, which are called fluorosilicone oils, but they have a high incidence of early emulsification and significant intraocular inflammation. Heavy silicone oil can also be produced by mixing PDMS with fluorinated hydrocarbons such as densiron, and the heavy silicone oil study showed that anatomic and functional success of densiron versus conventional silicone oil were similarly nice with inferior breaks and posterior PVR. Also, as heavy silicone oil tend to emulsify early, they should be kept in the eye for not more than 3 months. As we have mentioned, among lighter than water silicone oils, low viscosity silicone oils tend to emulsify earlier, but higher viscosity silicone oils are difficult to inject and remove, particularly with microincisional vitrectomy surgery. And one solution to this problem is adding high molecular weight polymers to low viscosity silicone oil, as in Siluron, which can delay emulsification without significant increase in viscosity. Surface tension and mild buoyant force of lighter than water silicone oil mechanically opposes the retina to the choroid. Since buoyant force exerted by silicone oil is less than gas, as we have mentioned, a silicone oil bubble inside the eye is more spherical and thus tamponades a smaller area of the retina as compared to a similar volume of intraocular gas. Advantages provided by silicone oil include closure of missed retinal breaks and new retinal breaks, and silicone oil is particularly indicated in patients with multiple inferior breaks and in eyes with traction retinal detachment, avoidance of excessive retinopathy, and less stringent requirement for post-operative head positioning. Patients can have some amount of useful vision through a silicone oil bubble, and air travel is safe with silicone oil inside the eye. So silicone oil is used to provide long-term post-operative retinal tamponade, and typical indications of silicone oil include proliferative vitreoretinopathy, giant retinal tear, and severe proliferative diabetic retinopathy with traction retinal detachment. Other indications for using silicone oil include macular hole in pathologic myopia, viral retinitis, retinopathy of prematurity, retinal detachment associated with choroidal coloboma, posterior segment ocular trauma, and in certain cases of endophthalmitis. Cataract develops in a high proportion of phakic eyes undergoing silicone oil tamponade. In phakic eyes with or without cataract, phaco-vitrectomy is often considered if silicone oil injection is planned or anticipated. Polymethyl methacrylate or acrylic intraocular lenses should be considered in this situation, while silicone intraocular lenses are contraindicated as silicone oil tend to adhere to posterior surface of these lenses through a posterior capsular defect, and this addition of silicone oil to the posterior surface of silicone intraocular lenses severely disrupt visual function, and this is very important to remember. But if an eye is planned to be left phakic following silicone oil injection, it too should undergo preoperative biometry, because if cataract develops in an eye with silicone oil, axial length is overestimated by ultrasound day scan through silicone oil, resulting in an underestimation of IOL calculation and hyperopic postoperative refraction if adjustments are not made in the recorded axial length. But axial length measured by optical biometry is almost the same with or without silicone oil, and eyes undergoing silicone oil injection should preferably not be left aphakic, which significantly increases the risk of keratopathy and pupil block. To prevent this silicone oil-induced rise in intraocular pressure due to pupillary block in aphakic eyes, an inferior peripheral iridectomy should be done intraoperatively as shown here in this diagram. And whether or not the eye is aphakic, overfilling of silicone oil should be avoided by keeping the intraocular pressure at approximately 10 mm of mercury by digital assessment at the end of surgery. Timing of silicone oil removal is not defined, and several issues need to be considered before removing silicone oil. Chorioretinal adhesion completes by 4 weeks, but silicone oil is retained in the eye well beyond this period to tamponade the retina so that reproliferation does not redetach the retina, and reproliferation is assumed to regress after several months. On the other hand, silicone oil should be removed before complications ensue, and we will be discussing these complications later in this session. So the general recommendation is to remove silicone oil after 2 months and before 6 months following injection of the silicone oil into the eye. It has been estimated that the mean time to redetachment, if it occurs following silicone oil removal, is 1.3 months, but if retina remains attached for 3 to 5 months after silicone oil removal, redetachment is unlikely. In certain situations, silicone oil is retained longer or even permanently, such as in eyes with poor visual potential, in eyes with hypotony who have a high risk of phthisis following silicone oil removal, and also in only seeing eyes with recurrent bad retinal detachments, but these eyes need to be closely monitored for the occurrence of silicone oil related complications. Unlike gas or silicone oil, which are used for post-operative retinal tamponade, perfluorocarbon liquids are used intraoperatively, and favorable characteristics of perfluorocarbon liquids or PFCL are optical clarity, specific gravity higher than that of water, immiscibility with and different refractive index from intraocular fluid and its constituents, thus maintaining its optical clarity and enabling its complete removal after intraoperative use. Low viscosity allowing easy injection and removal, high interfacial tension preventing subretinal migration, immiscibility with silicone oil allowing perfluorocarbon liquid silicone oil exchange in giant retinal tears as we will discuss, and a high boiling point and absence of interference with common laser wavelengths allowing endophotocoagulation under perfluorocarbon liquids. PFCLs are used intraoperatively, typically in giant retinal tears to unfurl the retina as seen here in these two photographs, to stabilize a detached retina, particularly that with proliferative vitreoretinopathy, to allow opening up of the funnel shaped detached retina, more thorough membrane dissection as seen here in this image, and vitreous base shaving in Rhegmatogenous retinal detachments with bullous configuration, and or when retinal breaks are located far anteriorly, to remove posteriorly dislocated nucleus or intraocular lens so as to float them anteriorly away from the posterior pole of the retina before removal, to remove intraocular foreign bodies, dislodge incarcerated retina, and displace subretinal blood from macula, to assist in drainage of suprachoroidal hemorrhage, and as a substitute of air if fogging occurs on the posterior surface of an intraocular lens with a posterior capsule defect following fluid-air exchange, which we will discuss later in this session. Perfluorooctane is the most commonly used perfluorocarbon liquid, and we may note here that this belongs to the same group of organic compounds as C3F8. At the end of surgery, PFCL should not remain in the eye, and this is very important to remember, as PFCLs cause inflammatory reaction and care needs to be taken to avoid passage of PFCL in subretinal space, which occurs more commonly in advanced proliferative vitreoretinopathy due to occurrence of iatrogenic retinal breaks. Stains can be used intraoperatively to visualize and safely manipulate transparent tissues. Triamcinolone stains vitreous gel and posterior vitreous cortex as shown here in this intraoperative photograph. Triamcinolone facilitates sparing of posterior lens capsule, complete removal of vitreous gel, induction of posterior vitreous detachment, and checking for residual areas of posterior vitreous cortex attached to the retina. Drawbacks of triamcinolone include intraocular pressure elevation and increased risk of endophthalmitis, but triamcinolone gets removed from the eye at the completion of vitrectomy. Although not often used, trypan blue can stain epiretinal membrane but can do so efficiently under air, and high concentrations of trypan blue can cause damage to ganglion cells and pigment epithelial cells. Indocyanine green and brilliant blue G dyes stain internal limiting membrane well with poor staining of the vitreous. ICG, intravitreal or subretinal, has been shown to cause retinal toxicity, so BBG is the preferred dye for ILM staining, and it stains the ILM blue as seen here in this intraoperative photograph. And BBG can stain the internal limiting membrane under fluid, and unlike indocyanine green, BBG does not cause retinal toxicity even after subretinal migration. Preoperative evaluation prior to vitrectomy includes anterior segment examination to assess anterior chamber depth in patients requiring tamponade, assess corneal and lens status, particularly with regard to clarity and the size of dilated pupil, presence and type of intraocular lens, and gonioscopy for synechia. Posterior segment evaluation should assess the presence and configuration of retinal detachment and the location of retinal breaks, status of posterior hyaloid, particularly with regard to its attachment to the retina, presence of epiretinal and subretinal membranes, and status of peripheral retina and vitreous base. Diagnostics include OCT to assess the vitreoretinal interface at the macula, detect cystoid macular edema, and differentiate full-thickness macular holes from lamellar and pseudo holes, USG in eyes with opaque media to detect retinal detachment and to assess the mobility of the detached retina if any, along with assessing location of vitreous and subretinal hemorrhage. As we have mentioned, biometry is required in eyes being considered for phaco-vitrectomy as well as for eyes being planned to be left phakic at the end of surgery, and CT scan is required to detect intraocular foreign body and injury to periocular structures in traumatized eyes. And systemic status evaluation is very important prior to surgery, including fitness for anesthesia. Vitrectomy can be done under local anesthesia, either peribulbar or subtenon, but general anesthesia is required for children and non-compliant patients. And as we have mentioned, when nitrous oxide is used as the inhalational anesthetic, it should be discontinued for at least 15 minutes prior to injection of gas. Then we come to the actual surgical techniques, and apart from the initial few steps, the remainder of the steps need not be performed in the order mentioned. In MIVS, self-retaining cannulas, as shown here in this photograph, are inserted through the sclera with the help of trocar needles. The cannulas can be valved, an example of which is shown here in this photograph, which limits egress of intraocular fluid from the eye. Otherwise, non-valved cannulas should be plugged when not in use to prevent egress of intraocular fluid through the sclerotomy. And conjunctival displacement, as shown here in this figure, is recommended during entry of the trocar and the cannula through the conjunctiva and the sclera, so that the conjunctival and the scleral entry wounds do not lie near each other, reducing vitreous leak through sclera or tear film entry into the sclerotomy, which increase the risk of endophthalmitis. The sclerotomy should be in an oblique single plane at 30 degrees to the scleral surface, as shown here in this figure, to achieve self-sealing of the sclerotomies after the cannulas are removed. And as we have mentioned, it is essential to confirm visually that the tip of the cannula, particularly the infusion cannula, has entered the vitreous cavity through the pars plana epithelium. The sclerotomy should be situated 3.5 to 4 mm posterior to the limbus in the region of the pars plana to avoid injuring the retina and the crystalline lens or an intraocular lens, and must avoid areas of conjunctival scars, filtering blebs, and abnormal areas of pars plana. Otherwise, the ideal sites of the sclerotomies, which provide most easy intraocular access to the surgeon, are a supratemporal sclerotomy, which should be on a straight line joining the lowest point of the superior orbital rim to the pupillary axis, a supranasal sclerotomy, which should be on a straight line joining the lowest point of the nasal bridge to the pupillary axis, and an inferotemporal sclerotomy, typically for the infusion cannula, which should be just below the horizontal meridian, so that inferior rotation of the eye causes least amount of bending of the infusion cannula. In patients with cataract requiring vitreous surgery, standard phacoemulsification is performed in the same setting as vitrectomy or prior to vitrectomy, and an acrylic intraocular lens should be placed in the capsular bag. Removal of the lens, whether clear or cataractous, without intraocular lens implantation is required in certain situations such as severe uveitis and severe proliferative vitreoretinopathy, particularly those with anterior fibrous or fibrovascular proliferation. Benefits of this procedure include decompartmentalization of the anterior and posterior segments of the eye, allowing faster clearance of inflammatory cells and mediators in the posterior segment through the anterior chamber angle, better intraoperative visualization and easier dissection of peripheral vitreous, and complete removal of the lens capsule, which prevents proliferation of peripheral lens matter and formation of iridovitrial and iridocapsular adhesions. But this technique is associated with an increased risk of neovascular glaucoma in eyes such as those with proliferative diabetic retinopathy. The technique for this procedure, along with vitrectomy, is often endocapsular lensectomy, which is performed through a posterior approach to the pars plana, in which, following placement of sclerotomy ports and anterior vitrectomy to remove vitreous adjacent to the lens, cutter is used to make a circular opening in the posterior capsule, following which hydrodissection and hydrodelineation is performed to dissect lens matter from the anterior capsule, as seen here in this photograph. Subsequently, Fragmatome is used to remove lens matter from within the capsular bag, as shown here in this figure. Cortex is removed with the vitreous cutter in cutting off mode, that is with suction only, as shown here in this figure, following which capsulotomy is made in the anterior capsule with the vitreous cutter in cutting on mode. Then an end gripping forceps is used to remove the capsular bag remnant in toto, as shown here in this figure. Similarly, in pseudophakic eyes with severe uveitis, severe proliferative vitreoretinopathy, and anterior fibrous or fibrovascular proliferation, removal of the intraocular lens may be required for better visualization and dissection in the retinal periphery. The sequence during vitrectomy in most situations is as follows. First, the anterior vitreous cortex is removed if required, followed by core vitrectomy, then removal of the posterior vitreous cortex, and finally peripheral vitreous base shaving. So if anterior vitreous cortex is taut or not transparent, it is removed first with vitreous cutter, as shown here in this diagram. This is typically followed by core vitrectomy, as shown here in this diagram and in this photograph. And as we have mentioned, triamcinolone can be used to highlight vitreous during its removal, as seen here in this photograph. If posterior vitreous cortex is attached to the retina, posterior vitreous cortex removal starts with induction of posterior vitreous detachment or PVD, as shown here in this diagram. After staining the vitreous with triamcinolone, posterior vitreous cortex is grasped at the nasal edge of the optic disc with the cutter tip in suction-only mode, applying high vacuum of around 650 mm of mercury. The cutter tip is then directed tangentially to the retinal surface and gently lifted up to the level of the equator, and the edge of the detaching posterior vitreous cortex should be carefully watched for development of iatrogenic retinal breaks. When removing posterior vitreous cortex attached to a retinal brake, as shown here in this diagram, care needs to be taken to avoid engaging the retina. So in this circumstance, cutting rate should be high and suction should be low to reduce vitreoretinal traction, but suction should be sufficient enough for efficient removal of cut vitreous. And if epiretinal membrane is present and needs to be removed, the epiretinal membrane can be peeled off before removing the posterior vitreous cortex, to which the epiretinal membrane is usually attached. In incomplete posterior vitreous detachment with a taut posterior vitreous cortex, as shown here in this figure, and which is found in many cases of traction retinal detachment, the taut posterior vitreous cortex is first entered with the vitreous cutter at a site away from the macula as well as the periphery, and the posterior vitreous cortex is truncated. If subhyaloid blood needs to be removed, it can be removed either with an extrusion cannula as shown here in this figure, or with a vitreous cutter in suction only mode. Peripheral vitreous cut should be trimmed with the vitreous cutter, applying low suction and high cut rate, while scleral indentation is applied by the assistant as shown here in this figure. As we have mentioned earlier, peripheral vitreous cannot be detached from the peripheral retina and can only be trimmed. In phakic eyes, particular care needs to be taken to not touch the crystalline lens, and many recommend that crossing over with an instrument posterior to the crystalline lens as shown here in this diagram should be avoided. In pseudophakic patients, posterior capsule can be removed with the vitreous cutter if opacification of the posterior capsule obscures visualization. Periretinal, either epiretinal or subretinal surface membranes are managed after vitrectomy. Two techniques can be used for epiretinal membranes: peeling and segmentation with or without delamination. As we have mentioned earlier in this session, peeling is used to remove less adherent membranes such as epiretinal membranes of early proliferative vitreoretinopathy and the inner limiting membrane in macular holes. With ILM forceps, the membrane is grasped and lifted off the retina and pulled in a direction from posterior pole towards the periphery, and peeling can be done under fluid or PFCL. Following vitrectomy, fluid refers to either the infusion fluid filling the vitreous cavity or aqueous secreted from the ciliary body. Segmentation with or without delamination is used to remove firmly adherent membranes, as is found in advanced proliferative vitreoretinopathy and proliferative diabetic retinopathy, in order to reduce the risk of iatrogenic breaks. In segmentation, as shown here in this figure, the membrane is segmented into islands between foci of adhesions, either with Bevel 25G27G vitreous cutter or curved scissors, as shown here in this figure. These islands of membranes can then be removed by using horizontal scissors, as shown here in this figure, by excising them parallel to and from the retina without pulling these membranes, and this is called delamination. Subretinal membranes need removal if they prevent attainment of normal macular contour. They can be removed by peeling, as shown here in this figure, or by scissor segmentation through an adjacent retinal brake or a retinotomy. Extrusion or removal of intraocular contents can be performed with backflush or extrusion cannulas attached to a second suction line. Alternatively, fluke needles can be used, but they need to be activated with fingertips and are thus less stable. The soft tip of these cannulas can be easily maneuvered through the retinal brake or retinotomy with reduced risk of choroidal injury. But in contrast to metal-tipped extrusion cannulas, soft-tip backflush cannulas are difficult to introduce through valved sclerotomy cannulas and have a higher tendency to engage the retina. Although metal-tipped extrusion cannulas can be used to remove firmer intraocular materials, the tips of these cannulas should not be introduced in the subretinal space. Hemostasis to control intraoperative bleeding should be initially attempted by rapid and transient elevation of intraocular pressure, but if bleeding does not stop with this maneuver, the site of bleeding should be coagulated with laser, which is preferred over endodiathermy. Peroperative systemic blood pressure control is also important to control intraoperative bleeding, and existing blood in the intraocular environment can be removed with extrusion cannula. A retinotomy may need to be performed to drain subretinal fluid when an existing retinal brake is not adequate for that purpose, or to access the subretinal space to remove subretinal membranes. Retinotomy to drain subretinal fluid should be done in an area of detached retina where periretinal membranes are not present or have all been removed so that this site is not exposed to vitreoretinal traction. The retinotomy can be performed posteriorly, peripheral to the supratemporal arcade, at least 1.5 disc diameters away from the optic disc, or more peripherally, avoiding large retinal blood vessels. Retinotomy for draining subretinal fluid is done in a detached zone of retina where subretinal fluid is adequate and is performed under air following fluid-air exchange. Diathermy is used to cauterize the planned site of retinotomy, and the cauterized area becomes necrotic and perforates along with hemostasis of retinal blood vessels at the site. And if necrotic retina does not perforate, a soft tip extrusion cannula or vitreous cutter can be used to enter the subretinal space through the necrotic area. The hole thus created has a white surrounding edge which helps in identifying the site later following retinal reattachment for retinopexy. And retinotomy to access subretinal space to remove subretinal membranes is done with a similar technique, but prior to fluid-air exchange in the area of taut retina overlying the subretinal membrane as shown here in this figure, following which the membrane is grasped with forceps and gently pulled out. Retinectomy or removal of a portion of the retina is indicated when membrane dissection fails to reattach the retina, as may occur with retinal contraction or retinal incarceration in traumatic wounds. Retinectomy as shown here in this figure is preferred over relaxing retinotomy as shown here in this figure, as removal of all tissue anterior to the cut reduces the risk of recurrent PVR and hypotony. And retinectomy involves removal of incremental portions of the retina with a cutter till the remainder of the retina is attached. Indications of photocoagulation during vitreous surgery include retinopexy around retinal breaks and retinectomies, which is preferably performed with continuous or painting laser, which in comparison to a row of laser spots provide more uniform tissue coagulation, less tissue damage, and more tensile strength of the retina RP adhesion. In addition, photocoagulation is also indicated to deliver panretinal photocoagulation in neovascular retinopathies such as proliferative diabetic retinopathy. It should be noted that panretinal photocoagulation is not required and should not be done in proliferative vitreoretinopathy, and photocoagulation can be performed under fluid-air or PFCL. Exchanges during vitreous surgery refers to replacement of one vitreous substitute with another following removal of the vitreous, and the substitutes include intraocular fluid, PFCL and air, which are used intraoperatively, and gas and silicone oil, which are used for post-operative tamponade. Fluid-air exchange refers to replacement of fluid with air, and this is used to close retinal breaks, drain subretinal and intravitreal fluid, and attach retina. Air is infused in the eye through the infusion cannula as shown here in this figure, while fluid is removed with a soft tip extrusion cannula attached to a suction pump. So in this figure, this is the portion of the vitreous cavity occupied by air, and this is the portion of vitreous cavity occupied by fluid. And as fluid is removed from the vitreous cavity by the suction pump, air occupies the entire vitreous cavity. To remove intravitreal fluid, the tip of the cannula is positioned over the optic disc, and to remove subretinal fluid, the tip of the cannula is positioned in the subretinal space. It is important to remember that in the presence of retinal breaks, subretinal fluid drainage should be started before fluid-air exchange is started, and subretinal fluid drainage continued while fluid-air exchange takes place. But if fluid-air exchange is initiated before initial subretinal fluid drainage, subretinal fluid can displace posteriorly towards the macula. And during fluid-air exchange and drainage of subretinal fluid, passage of air in the subretinal space and its location indicates the presence and location of residual traction. Fluid in the vitreous cavity can also be replaced with PFCL, typically partially, and as we have mentioned earlier, this is typically required to unfurl giant retinal tears, enable membrane dissection in proliferative vitreoretinopathy, and to remove dislocated crystalline lens, intraocular lens, and intraocular foreign body. PFCL is injected with a dual bore cannula, with one bore meant for injecting PFCL into the eye and the other bore to remove fluid from the eye. And the rate of PFCL injection should be gradual but sustained to allow anterior displacement of subretinal fluid, flattening of posterior retina, and unfolding of posterior flap of a giant retinal tear, as we will discuss later. Initially, a small bubble of PFCL is placed over the optic nerve head as shown here in this figure, and the PFCL bubble is then enlarged by continuing injection of PFCL with the dual bore cannula. The tip of the injection bore of the cannula maintains contact with the top of the PFCL bubble as shown here in this figure, and the tip of the extrusion bore of the cannula remains above the PFCL bubble. And peeling, endodiathermy and laser can all be done under PFCL. After PFCL has served its purpose, PFCL is replaced with air except in giant retinal tears where PFCL should be replaced with silicone oil, as we will discuss further. For PFCL-air exchange, a soft tip backflush cannula is placed peripherally over the top of the PFCL bubble while air is infused through the infusion cannula. This replaces all intraocular fluid with air before PFCL is removed completely by gradually progressing the cannula posteriorly. Following subretinal fluid drainage, retinal attachment and retinopathy, air in the vitreous cavity can be replaced with gas or silicone oil for long-term retinal tamponade. For air-gas exchange, non-expansile concentration of the gas is injected through the infusion cannula, and the soft tip cannula can be positioned over the optic disc during this time to remove any residual intraocular fluid. Insufflation of at least 25 ml of the non-expansile mixture is required to adequately displace air and any residual intraocular fluid. Air may be replaced with silicone oil when longer-term retinal tamponade is desired, as shown here in this figure, with this being the enlarging silicone oil bubble and this being the portion of the vitreous cavity filled with air, which gradually decreases. For air-silicone oil exchange, silicone oil is injected from a syringe with a short straight cannula, which is inserted through the superotemporal or supranasal sclerotomy cannula and not through the infusion cannula as with gas, using an automated pneumatic injection system called viscous fluid injector or VFI attached to the syringe. Air escapes through the other sclerotomy cannula, either supranasal or supratemporal, whose valve is kept open with a vent, and this is continued till the silicone oil bubble inside the eye touches the posterior capsule or reaches the pupillary plane in an aphakic eye and flows out of the vent and also into the infusion cannula. And as we have mentioned earlier, IOP should be assessed digitally and should be around 10 mm of mercury at the end of the procedure to avoid overfill with silicone oil. And if anterior chamber shallowing occurs during this process, viscoelastic can be injected in the anterior chamber and retained with administration of post-operative oral acetazolamide. As we have mentioned earlier, PFCL should be directly replaced with silicone oil in eyes with giant retinal tear, as replacing PFCL with air in these eyes followed by replacement of the air with silicone oil may cause slippage of the flap of a giant retinal tear when the incoming air during PFCL-air exchange displaces intraocular fluid posteriorly through the giant retinal tear to the subretinal space. For PFCL-SO exchange, following a full PFCL fill, silicone oil is injected with a viscous fluid injector through the supratemporal sclerotomy cannula. The silicone oil fills the vitreous cavity from anterior to posterior and remains anterior to the PFCL bubble. Simultaneously, PFCL is removed with a cannula introduced through the supranasal sclerotomy cannula, and the tip of the cannula is positioned within the PFCL bubble. Both silicone oil and PFCL being hydrophobic, they remain in contact with each other, excluding intraocular fluid from their interface, and minimizes the entry of intraocular fluid into the subretinal space as their interface crosses posteriorly across the giant retinal tear. In silicone oil removal, silicone oil in the vitreous cavity is replaced with infusion fluid. In phakic or pseudophakic eyes, 2 pars plana ports are made and infusion is started from one port. Through the other port, an extrusion cannula attached to a suction pump is introduced into the eye and its tip positioned within the silicone oil bubble and high suction of 500 to 600 mm of mercury applied. In an eye with lighter than water silicone oil which floats over infusion fluid, this port is positioned as superiorly as possible. In aphakic eyes, an alternative option is to remove silicone oil through a limbal incision while an AC Turner maintains the intraocular pressure. and during silicone oil removal, other procedures which are often performed include epiretinal membrane removal, 360 degrees peripheral retinopexy, and phacoemulsification. Then we'll discuss the algorithms in specific scenarios commonly encountered. In Rhegmatogenous retinal detachment, the sequence is usually placement of ports, core vitrectomy, marking of retinal breaks in detached retina with endodiathermy, induction of posterior vitreous detachment if incomplete, peripheral vitrectomy, fluid-air exchange with drainage of subretinal fluid through retinal breaks, endolaser retinopexy, followed by tamponade. In giant retinal tear, following placement of ports, core vitrectomy and removal of peripheral vitreous, PFCL is injected to unroll the posterior retinal flap of the giant retinal tear and flatten the retina, and the retinal flap anterior to the giant retinal tear is excised. Membrane dissection of associated PVR is performed if required, followed by endolaser retinopexy with placement of 3 to 4 rows of burns posterior to the giant retinal tear, followed by PFCL-SO exchange as we have discussed. In proliferative vitreoretinopathy, many prefer to place an external sterile band followed by placement of ports and core vitrectomy, following which PFCL is injected to open up the funnel and stabilize the retina for membrane dissection. This is followed by thorough preretinal membrane dissection from posterior pole anteriorly up to the vitreous base till retina is completely flattened and attached, and this includes vitreous base shaving and, if required, subretinal membrane dissection and retinectomy. This figure shows a retinectomy being made to excise an area of contracted retina. This is followed by PFCL-air exchange, drainage of any residual subretinal fluid, and endolaser retinopexy around retinal breaks. Finally, air is exchanged with gas or silicone oil for long-term post-operative retinal tamponade, and the silicone study showed that in eyes with proliferative vitreoretinopathy, SF6 is inferior to both C3F8 and silicone oil, although differences in outcome between silicone oil and C3F8 were not statistically significant. Incidence of hypotony was lower with silicone oil as compared to that with C3F8. The algorithm for proliferative diabetic retinopathy is placement of ports, core vitrectomy with removal of vitreous hemorrhage, PVD induction, membrane dissection in diabetic tractional retinal detachment, endolaser photocoagulation, followed by tamponade. Removal of dislocated lens fragments in vitreous cavity should be performed within 3 to 7 days of cataract surgery. Following placement of ports, core vitrectomy should be performed with freeing of the fragments from adherent vitreous, and this is very important to remember. Perfluorocarbon liquid can be used to lift large fragments anteriorly from the posterior pole as shown here in this figure. The lens fragments are then removed with vitreous cutter if the nucleus is soft, or fragmatome if the nucleus is hard. Fragmatome requires a 20G port, and initially only aspiration is applied to bring the lens fragments in the mid-vitreous cavity, and only then ultrasound power is initiated. Initial ultrasound power setting of the fragmatome should be low and increased as required. Following removal of lens fragments, meticulous examination of the entire, particularly the peripheral retina, is extremely important because giant retinal tears can occur due to aggressive attempts to remove lens fragments in vitreous cavity during cataract surgery, and these giant retinal tears typically occur more commonly in the quadrant opposite to the cataract surgery incision. Similarly, for dislocated intraocular lens in vitreous cavity, core vitrectomy is first performed with freeing of the intraocular lens from adherent vitreous, following which PFCL can be used to float the intraocular lens anteriorly from the posterior pole of the retina, and the same intraocular lens can be either repositioned or exchanged for a new intraocular lens. Following this, posterior vitreous detachment is induced, and the entire, particularly the peripheral retina, is meticulously examined for retinal breaks. In macular hole, initially core and peripheral vitrectomy is performed, followed by induction of PVD and peeling of ERM if any. This is followed by peeling of internal limiting membrane after staining the internal limiting membrane with brilliant blue G dye. This is followed by fluid-air exchange, during which subretinal fluid is drained from the macular hole, followed by air-gas exchange for post-operative gas tamponade and post-operative face-down head positioning. For intraocular foreign body, following primary repair of globe and placement of sclerotomy ports, core vitrectomy is performed with freeing of intraocular foreign body from adherent vitreous. Then the intraocular foreign body is removed with intraocular foreign body forceps or magnets through an enlarged sclerotomy or through the limbus. This is followed by management of associated retinal breaks and membranes as required. In endophthalmitis, following placement of ports, 0.2 ml to 0.5 ml of undiluted vitreous sample is collected with cutter for cultures. Following this, core vitrectomy is performed to remove vitreous exudates, but PVD induction and peripheral vitrectomy are contraindicated in endophthalmitis, and this is very important to remember because the inflamed retina in these eyes is extremely prone to develop iatrogenic retinal breaks during vitrectomy. And following core vitrectomy, antimicrobials are injected intravitreally. We have a few video clips here, and we must note that although the view of the anterior segment in these videos are upright, the view of the posterior segment in these videos are inverted both horizontally and vertically, but the surgeon's view of the posterior segment through the eyepieces of the microscope remains upright because of SDI. Complications of vitreous surgery include cataract, with nuclear sclerotic cataract occurring in a high proportion of patients older than 50 years of age within 3 to 6 months of vitreous surgery, and cataract can also occur intraoperatively due to lens touch with instruments, raised intraocular pressure. Hypotony, which may occur in early post-operative period due to leakage from sclerotomies, which is more common with MIVS, in which sclerotomies are not closed with sutures, or hypotony can occur in late post-operative period either due to increased uveoscleral outflow through large retinal breaks or decreased aqueous production due to tractional or exudative ciliary detachment or ciliary atrophy. Attempts at surgical repair of ciliary body detachment have been disappointing, and silicone oil can be injected and retained indefinitely in eyes with intraocular pressure less than 10 mm of mercury. Retinal breaks or Rhegmatogenous retinal detachment can occur intraoperatively or post-operatively, and proliferative vitreoretinopathy, particularly anterior hyaloidal fibrovascular proliferation, can occur post-operatively. Other complications of vitreous surgery include retinal or vitreous incarceration in sclerotomy wounds, suprachoroidal or vitreous hemorrhage, post-operative massive fibrin exudation, which typically occur in diabetic patients, an example of which is shown here in this clinical photograph. Anterior segment neovascularization and neovascular glaucoma, photic maculopathy or light toxicity of retina, endophthalmitis, and sympathetic ophthalmia. Gas-related complications include cataract, which is usually feathery posterior subcapsular cataract, mild forms of which may disappear following decrease in volume of the gas, raised intraocular pressure, usually due to overfill or expansion of gas, which is not compensated by the outflow facility of the eye, migration of gas into the subretinal space, which occurs due to persistent vitreous traction on retinal brake and or a gas bubble whose diameter is smaller than the size of the retinal brake, and subretinal gas keeping the retinal brake open requires removal. Migration of gas into the anterior chamber, which is likely to occur in aphakic eyes and pseudophakic eyes with disrupted posterior capsule, and long-term contact of gas with corneal endothelium may lead to corneal decompensation. Hypotony due to underfilling of the eye with gas or leakage of gas through sclerotomies, and optic capture, which can occur following phaco-vitrectomy. Silicone oil related complications include refractive error, and provided lens surgery is not performed along with vitreous surgery, silicone oil injected in the vitreous cavity causes a hyperopic shift from preoperative refractive status in phakic and pseudophakic eyes, and myopic shift from preoperative refractive status in aphakic eyes. Cataract develops in a high proportion of patients left phakic following surgery with silicone oil injection, and early post-operative cataract is usually in the form of feathery posterior subcapsular cataract, but later nucleus sclerosis develops, and cataract surgery in a phakic eye filled with silicone oil can be done along with or without silicone oil removal. Biometry issues need to be sorted out accordingly, and silicone oils must not be used in this scenario, as we have discussed previously. Silicone oil emulsification is breaking up of a silicone oil bubble into smaller droplets, as seen here in this clinical photograph. This occurs when surfactants lower interfacial tension at the surface of the silicone oil bubble. These surfactants include phospholipids, proteins, lipoproteins, and cellular debris. Silicone oil emulsification usually takes place few months after silicone oil injection, and higher viscosity silicone oil tend to emulsify later, whereas heavy silicone oil tend to emulsify earlier. Emulsified silicone oil can cause inflammation, glaucoma, and proliferative vitreoretinopathy, and this is important to remember. Silicone oil can migrate into anterior chamber, as seen here in this clinical photograph, and this can lead to corneal endothelial and or trabecular damage. This can occur intraoperatively or early in post-operative phase due to aphakia, zonular defects, disrupted posterior capsule, or blockage of the inferior peripheral iridotomy, and late migration of silicone oil into the anterior chamber can occur due to hypotony or recurrent retinal detachment. Emulsified silicone oil in the anterior chamber may accumulate in its superior portion, as seen here in this clinical photograph, and this is called a hyperoleon. Multiple bubbles of silicone oil in anterior chamber are easy to detect, but full fill of anterior chamber with silicone oil may be difficult to diagnose. Management options of silicone oil migration in anterior chamber include injection of air or viscoelastic in the anterior chamber, opening a blocked inferior PI with viscoelastic, and or silicone oil removal and re-injection. Silicone oil can cause angle closure glaucoma either due to pupil block, which typically occurs in an aphakic eye in which an inferior PI is either blocked or has not been created, or forward movement of lens iris diaphragm due to silicone oil overfill, which can occur irrespective of lens status. Silicone oil can also cause open-angle glaucoma either due to mechanical blockage of trabecular meshwork or inflammatory damage of trabecular meshwork caused by emulsified silicone oil. Management of silicone oil-induced glaucoma include creation or reopening of inferior PI in eyes with pupil block, intraocular pressure lowering medications, silicone oil removal, but silicone oil removal may not be effective in lowering intraocular pressure, glaucoma drainage devices instead of trabeculectomy because subconjunctival silicone oil can promote subconjunctival fibrosis and induce failure of trabeculectomy or transscleral cyclophotocoagulation. Keratopathy due to silicone oil can manifest as band keratopathy early on, as seen here in this clinical photograph, or endothelial decompensation later. Retained PFCL can cause retinal damage from vasoconstriction, inflammation, or mechanical pressure on the retina, as well as corneal endothelial toxicity and secondary angle closure glaucoma from trabecular damage. Retained PFCL can be found in the vitreous cavity, as seen here in this clinical photograph, in the subretinal space, as seen here in this clinical photograph, and on this OCT, or in the anterior chamber, as seen here in this clinical photograph, where it is typically located inferiorly. Vitreous surgery or parts planar vitrectomy is indicated for removal of vitreous opacities such as hemorrhage, exudates, and intraocular foreign bodies, relief of vitreoretinal traction, closure of retinal breaks, and accessing the subretinal space. PPV consists of making 3 sclerotomies: an inferotemporal port for infusion, a superotemporal and a suprarenasal port to introduce endoilluminator and various instruments. A 4th sclerotomy is occasionally required for fragmatome, intraocular foreign body forceps, and chandelier illumination. Visualization of the posterior segment through a surgical microscope can be provided with contact lenses or non-contact systems. Currently, transconjunctival sutureless vitrectomy, also called microincisional vitreous surgery or MIVS, is preferred as it does not require peritomy, or conjunctival or scleral closure with sutures has a lower risk of iatrogenic retinal breaks and provides less discomfort and faster visual recovery to the patient. The steps of PPV include sclerotomy creation with trocar cannula systems, introduction of infusion cannula whose tip should be confirmed to be in the vitreous cavity before starting infusion, followed by vitrectomy with vitreous cutter, while intraocular illumination is provided by an endoilluminator. Sequence of vitrectomy is usually removal of anterior vitreous cortex, followed by core vitrectomy, then induction of posterior vitreous detachment, and finally trimming of peripheral vitreous cortex. Additional maneuvers which may be required include extrusion, membrane dissection, retinotomy or retinectomy, hemostasis, endolaser, and use of intraocular tamponades. Stains which can be used to visualize transparent tissues intraoperatively include triamcinolone for vitreous, brilliant blue G for internal limiting membrane, and trypan blue for epiretinal membrane. Tamponades are used to close retinal breaks and oppose the retina to RPE choroid. The properties of tamponading agents which are of use for this purpose are surface tension and buoyancy. Intraoperative tamponade can be provided with PFCL, a heavier than water liquid, which is used in PVR in giant retinal tears and for removal of lens fragments, intraocular lens, and intraocular foreign body from vitreous cavity. PFCL should not be left in the eye and is exchanged with air or silicone oil after use. Post-operative tamponade can be provided with either gas or silicone oil. During parts planar vitrectomy, non-expansile gas air mixtures are used. If vitreous surgery is performed under general anesthesia with nitrous oxide as the inhalational anesthetic, nitrous oxide needs to be stopped 15 minutes prior to initiation of gas injection. The gas bubble in the vitreous cavity floats upwards, so post-operatively, patient's head position should maintain the retinal break uppermost within the eye. Air travel needs to be avoided till the gas bubble completely disappears, which usually occurs within 2 to 6 weeks. Silicone oils are used to provide longer-term post-operative tamponade. Apart from surface tension and specific gravity, which determines buoyancy, viscosity is another important property of silicone oil. Conventional silicone oils are lighter than water and so provide an upward buoyant force which is a bit lower than that provided by gas. Heavy silicone oils are also available which provide downward force within the eye, but their efficacy in comparison to conventional silicone oils is yet to be determined. Viscosity is an independent property. Among lighter than water silicone oils, lower viscosity silicone oils are easier to introduce and remove from the eye but undergo emulsification earlier as compared to higher viscosity silicone oils. Except in certain circumstances such as eyes with poor visual potential and hypotony, silicone oil should be removed from the eye within 2 to 6 months following injection to avoid complications from emulsification. Ultrasound biometry in eyes with silicone oil tends to overestimate axial length and underestimate intraocular lens power, resulting in hyperopic refractive error following silicone oil removal if adjustments are not made in the recorded axial length. Complications of pars plana vitrectomy include cataract, raised intraocular pressure, hypotony, recurrent retinal breaks, retinal detachment, and proliferative vitreoretinopathy, vitreous and/or suprachoroidal hemorrhage, vitreous and/or retinal incarceration in wound, fibrin exudation, anterior segment neovascularization, endophthalmitis, and sympathetic ophthalmia. Gas-related complications include cataract, raised intraocular pressure, hypotony, and subretinal or anterior chamber migration of gas. Silicone oil-related complications include refractive shift, cataract, anterior chamber migration of silicone oil emulsification, glaucoma, and keratopathy. Retained perfluorocarbon liquids can cause toxicity, retinal, corneal, endothelial, and/or trabecular. Thank you for listening.